Thank you. Thank you. Great. So I'm going to spend the next 10 minutes talking a little bit about an overview of some of the projects that are being launched at the federal level, and then Dr. Moran is going to talk about how it impacts the geriatric population. You saw a similar slide like this by Dr. Sinopoli earlier in this morning, but it really shows, I think this slide shows how, for the most part, U.S. wealth has maybe increased slightly, but U.S. health spend per hospital has increased by 42.87% from 1970 to 2010. So I think it dramatically increases, indicates the problem that we have. Another issue is that we recognize that the number of beneficiaries are dramatically increasing and the number of workers per beneficiary to support all of those benefits are decreasing. So because of that, in order to maintain the Medicare Trust Fund, CMS has launched several programs in which we are looking at ways at a federal level in terms of redesigning healthcare, including having a different way in which we pay. This is a very important slide. This is a slide that came from a JAMA article that Dr. Brurick published in 2012, and this slide a lot of times is referred to as the wedge slide, and that basically shows in each of the categories what are the opportunities for savings for the U.S. healthcare. So for instance, failures of care delivery, those would be patients that have medical errors, had wrong site surgeries, or in fact physicians were not following, or other clinicians were not following best practice protocols. The second one would be failures of care coordination. Those are increased risk for readmission because we don't have a way in which we are coordinating care across the continuum. And so patient-centered medical homes would be one of the things that we put in place to decrease that. In each of these, there have been savings quantified with an average. What you typically hear in the country is that they estimate about 30% of all that we spend in the United States, 30% of it could be redirected and probably can be classified as waste. So a common set of definitions is the two most important programs, well, there's three programs. One is patient-centered medical home, second one is bundle payments, and third is MSSP. Those are the three in which there is a lot of focus in terms of supporting care redesign. I get people ask me all the time, what's the difference between shared savings and shared risk? Shared savings is an upside only. Shared risk, you have an upside and downside. And right now, MSSP is only an upside. There is no downside at all. Here are the payment models in relationship to each other. It starts with a fee for service, goes to bundle payments, go to shared savings, and then ends up in capitation. So these are all building blocks to a more fully integrated system. Early in the fall of 2014, Marilyn Tavernier and Dr. Conway published a paper in JAMA in which they actually take the 4 types of payment models and put them in a category. Category 3 are bundles of medical homes, and Category 4 are population-based capitated payments like Medicare and Advantage. And then you saw the slide earlier today with Dr. Sinopoli in which he talked about in January, HHS announced that they want to move by 2018 the payments, 50% of the payments to be in categories 3 and 4, which is bundle payments and ACOs. So looking at this slide, this shows us in terms of this was the pilot that started MSSP, and it started with physician group practice demo. It was 10 sites over 5 years, and we found some results from this, and this was the demo that started helping CMS begin to understand what are the variables that need to be put within the MSSP. So the results indicated that ACOs have a challenge in terms of achieving savings within 5 years. It takes a long time for that type of integration to be hardwired within the system, for care to be redesigned along the continuum, and for the ACO to achieve savings. So everyone is recognizing that ACOs is more long-term in terms of what we're going to do in terms of reaping the benefit. The other thing that was identified is that having a system in which you have a foot in the fee-for-service camp and the foot in a population base is very difficult to manage. So you have a CFO that says, I need to fill my beds because that's how I get paid, and then you have the VP of clinical integration that says, I get a payment for keeping people healthy and out of the hospital. And so the study did indicate the difficulty in terms of managing both of those business models. There are 3 types of accountable care organizations. 2 have been launched, and the 3rd one should be launched rather soon here. The 2 are Medicare Shared Savings Model, and then a Pioneer, and then the 3rd one is Comprehensive End-Stage Renal Disease, and that should be very rapidly here being launched. MSSP, and you saw this results with Dr. Snopely's talk this morning. 405 total ACOs serving about 7.2 million beneficiaries. Now, 50% of all the ACOs do make money. But as his slide indicated, of that 50%, 25% of the total will get savings back to the ACO. So what happens is 50% will get savings, but in order for the ACO to get the savings, they have to go over a minimum savings threshold. And so only 50% of those were able to go over that. So when you are looking at ACOs from a CMS perspective, 50% of them had savings to the Medicare trust fund. But of those 50%, only half of those were able to go over the threshold enough to allow the ACO to have some shared savings. Some of the issues that have been identified with the MSSP, and one of the important ones I want to talk about is socioeconomic factors. We're beginning to realize the impact of socioeconomic factors in caring for the patients. And Dr. Monroe here will be talking in terms of some of the things that he's doing in terms of looking at some of those. So it's not just resolving the health factors in terms of being able to care for the patient along the continuum. There are things such as being able to have transport to the doctor's office, transportation to pick up your medications that do impact you. We recognize that impact to the providers that PAC, a post-acute fragmentation, and we see that after a ACO is up and running, we typically can see a decrease by 30% of all the different post-acute providers. Some ACOs can have as many as 200 different skilled nursing facilities that they're working within. As time goes on, that consolidation happens. They're able to identify which one of the skilled nursing facilities have the best outcomes for their patients, and so they begin more of a long-term partnership with that. And this slide indicates that the larger you are in terms of an ACO, the better that you are. So with that, I will.
Thank you very much. So just to reiterate, though, that the social factors, I'm a division chief of general internal medicine. I have the sort of nice, I'm sorry, I'm just going to lean. I'm able at MUSC to test PCMH concepts within a small group. So I have a resident and faculty practice. It's 12,000 patients in total, which is the minimum size for an ACO, but they're not all Medicare recipients. But our goal was to sort of test re-engineering strategies for how we would make a PCMH transformation. The second goal is that we train physicians, and currently we train physicians for the way we used to practice. And really what we need to do is train physicians for the way we will practice. So you all heard the three sort of new delivery system models that are coming out of ACA, accountable care organizations, bundle payments, and patient-centered medical home. And I actually want to spend a little bit of time at the ground level in PCMH. So you heard about accountable care organizations. They're succeeding, some of them. These are the joint principles of the patient-centered medical home. Ongoing relationship within a team, with each patient has an ongoing healing relationship with the physician or other provider. They practice within a team. It's a whole person orientation. I make the joke that you really can't have a patient-centered medical home for the left lobe of the liver. Care is coordinated and integrated. Quality and safety are very focused areas. Enhanced access and payment. And these four groups don't agree on many things, but they agreed on this. This is a sort of outline of what we did at MUSC and how over the last 4 years we've gone from just being a certified medical home to actually living medical home kinds of concepts. So the first thing I did was develop a clinical leadership team. It's not just physicians. There are 3 physicians on the team. There are 3 nurses, a nurse director. There's a pharmacist, an outreach physician. There's actually 2 pharmacists. One of them is the project director. And so we meet weekly and work through issues. Second thing we started doing was looking at who we took care of. And yesterday I talked about the medical home, some of the sort of descriptions of the population that we serve. We have pretty sick people, high utilization patterns, lots of chronic illnesses. And so we started thinking about not necessarily the folks we were seeing, but the folks we were not seeing, and started looking at data for things like associations with utilization and things like that. One of the things we found pretty quickly was that an independent predictor of utilization was being in a couple particular zip codes. Others were things like not coming in for clinic. So if you were in the clinic less than 80% of the time you were scheduled, that was actually an independent predictor of utilization. So reaching out to particular populations with lower socioeconomic status from lower socioeconomic zip codes and those kinds of things was some of the interventions we linked to populations. We moved from doctors to teams. We redefined what every team member did or just reinforced the original definition, and then started moving them from the role that they did to the role we really needed them to do going forward. And yesterday in the medical home lecture, which is, you have a copy of the slides, we walked through sort of some of the reasons why. A 66-year-old woman comes in with dysuria and otherwise healthy. There's 1 or 2 tasks. There's preventive care and there's treating a urinary tract infection. 96-year-old woman with advanced dementia, atrial fibrillation, hypertension, diabetes, a stressed out caregiver, and delirium. There's several more problems there. We need the team to sort of assemble around the sicker patient, and we can leave providers, not unsupported, but less supported for the easier populations. So our team is really focused on sick folks. We also had to re-engineer our microsystem. What we do in the clinical setting may not make sense as we go forward. So having an LPN fax things to a nursing home, it doesn't make sense. They're not working at the top of their license, and we need another process by which we can do things that routinely are done. We measured the number of communications into our practice, 36,000 patient communications a year. How we route messages through our practice is not only an efficiency, but it's a clinical effectiveness and safety challenge. And so we very closely looked at how we manage communications from patients. And there are lots of other microsystem changes. And then the critical importance of data. We don't know what we're doing unless we measure our impact. And over the course of 4 years, we've reduced emergency department visits by 25%. We've reduced admissions to the hospital by 16%. And we're continuing to sort of develop interventions to continue to sort of work on that utilization. But we've also at the same time increased quality. So our blood pressure controls and our A1C control rates are higher than they were. And not a small part of that was outreach. When patients were lost to follow-up and their last A1C was 9, well, we need them back in. We need them under better control. Otherwise, that 9 is going to sit in your report. So we needed to know how well we did. So some of the things I thought I'd talk about, one is time horizons. So when we start a 45-year-old person on a statin or something else like that, we're looking at a time horizon of, say, 30 or 40 years. If we start a 90-year-old on a statin, the time horizon's about 4.5 years. And are we going to have an impact in the next 4.5 years of using a statin? Probably not. So time horizon's really important. Another thing is access. When folks are older, they're a little sick, if they start getting sick, they need access, because folks get sick pretty quickly if you have lots of comorbidities. So we have to actually be very facile about how we manage access. If we don't provide access, they'll end up in the emergency room. Risk stratification. We need to know who to focus on. You all have heard of the 80-20 rule. 80% of the cost, 20% of the patients. So we can identify who our top 20% are, who our top 10% are, and we started realigning our care teams around risk. We also did a lot of generic interventions. So we all think about disease-specific interventions, like if you weigh yourself every day and you gain 3 pounds, you should call us and we'll change your diuretic. But what about generic interventions like how do we maximize medication adherence across all patients? As you know, I mean, most older folks are at least on 1 or 2 medications, many are on way more than that. How do we get high adherence rates? How do we enable patients to be more able to take all their medications? So generic interventions like that. Generic interventions like fall risk reduction. And then geriatric syndromes. Fall is one, but there are others. Delirium, dementia, polypharmacy is incredibly important, is a really important issue. And then especially end-of-life care and capacity. So do we help patients and families and caregivers work through end-of-life decision-making in the clinic or 2 weeks into an ICU stay on a ventilator? That's one of the, I think, challenges we have going forward. All we've done with 2 weeks on the ventilator is prolong the dying process. We haven't actually sort of prolonged life. Technically, yes, but not really. And so end-of-life care, I think, is going to be one of those critical issues that we're going to have to put on the, on the front end of these kinds of things. So access to care, not just walking into the clinic, phone, email, not unsecured email. We really discourage that. But this is through our electronic record system. We have same-day access. We have night coverage. And we have scheduled patients as well. We haven't gone to completely open access. And then outreach. Outreach is actually critical. We started looking at our patients who were out of control. They were also from hotspot zip codes where we knew there were social barriers and economic barriers to care. We assigned our outreach coordinator to basically break down barriers, make sure folks came in, were able to get in, were able to get what they needed. And our quality indicators changed relatively remarkably after starting our outreach strategies. So really, one of the challenges is what risk are we managing? So we're managing risk of hospitalization. What other risks are we managing? And I think that's something we really have to think about. We do risk stratification all the time in healthcare. So what are the risks that older folks face? And then what risks can we mitigate? And then what other risks can we anticipate and prevent? And hospitalization is one of those risks that we do have a chance of reducing. But I'll give you an example. Somebody gets hit by a bus, we can't mitigate that risk. But if somebody falls and has the same kind of trauma, that is a risk that we can probably mitigate and maybe even prevent. So, generic interventions, access to care, medication adherence, care coordination, and preventive care. How many times have I heard, oh, the doctor was supposed to send you something? Well, it may be that the only time I hear about a hospitalization is when a patient comes in and says, well, I was in the hospital, didn't they send you something? We have started to very proactively have our team notified about when someone's in the emergency department, somebody's in the hospital, and proactively reach out. Transitional code management is one of those strategies. It's reimbursed by CMS. Within a month of TCM codes being approved by CMS, we were doing transitional care management. And so a patient gets a phone call from one of our nurses within 2 business days, 75% of the time. And then there's the geriatric syndromes. I talked about polypharmacy. It's just incredible. Our fee-for-service system drives polypharmacy. You can spend 20 minutes trying to figure something out. You can work with a patient and a caregiver about a syndrome, or you can start a med. Which ones takes less time, and how quickly can you get the patient out of the room? It drives it. And then functional status. Functional status is an independent predictor of bad things happening. So as people lose mobility, whether it's disease-driven or age-driven, it increases their risk. And not surprisingly, dementia, depression, delirium, they're all sort of comorbidities we have to look for in older populations. And then finally, caregivers. If the caregiver goes down, the patient goes down. And so caregiver stress is something that I think we'll be working toward in the future. And obviously, you know a lot about the sort of disease-specific interventions, but remember, we're trying to maximize quality of life, not just longevity. And so stabilizing and preventing progression is a huge part of what we do. And this is huge. How do we negotiate end of life on the front end of care? When we know it's coming, the patient knows it's coming, the caregiver knows it's coming. Those are complex conversations we have to have, and we can't do it in a 20-minute visit. But they are incredibly important, both for quality of life and the quality of death. I mean, there was once a palliative care doc who was speaking, and she said, you know, Americans are the only people who think death is optional. And when they finally accept it, they want it latte. So we need to have these conversations, which are difficult to have, but actually we've talked to our patients. More than half of our patients want to have these conversations. We don't bring it up. So how do we do all that stuff? Well, we need more front-end resources, and what I've heard a lot at this conference is, how do we get the resources to do this? And I think Dr. Sinopoli talked about sort of transitioning too early, transitioning too late. What I worry about is that transition is years. It's not, I'm going to call down from the C-suite and Monday, we're going to be an ACO. I use movie metaphors a lot. I think about the Titanic and the 2 guys up there, and all of a sudden they see the iceberg. And they throw the helm over to port, and nothing happens. They just plow into an iceberg. Because these are huge organizations. These docs and nurses have been doing what they've been doing for 20 or 30 years. They're not going to change course fast. It's a culture shift and a dramatic change in the way we think and practice. These are the kinds of things we do now. They're going to be different. So, finally, as we think about the expected care needs of aging baby boomers, what do we need to do? We need new models, and new model success is very much dependent on 2 local factors: effective care teams and management of clinical operations, local operations, the clinical microsystem. And I think these are not issues you can manage from the C-suite and from sort of the contract room. This is stuff that has to happen in the clinic over time. So as we were talking about earlier, the MSSP program is a no-risk kind of contract. We should be taking advantage of that. We should sign up and learn how to do this, because inevitably we're going to be at risk. And when we go to risk, we don't want to be the Titanic. Throw it to port and still plow into an iceberg. So, thank you.